We are starting the industry symposia by the Hilton Pharma. I would request the panelist of the session. The first panelist of the session is Dr. Professor Khurshid Ahmed Khan. Sir is the most decorated endocrinologist. I have a huge list of achievements. You can read from the slide. Sir is a former PES president, and he is the chief editor of the JPES as well. Moving on to the second panelist of the session, Professor Tariq Wasim. He is the head of Department of Internal Medicine at Salim Memorial Hospital, Lahore. Sir, please join us on the stage. He is the Senior Vice President of Pakistan Society of Internal Medicine. The third panelist of the day is Dr. Bashir Hanif. He is the Executive Director at Tabba Heart Institute, Karachi. He is the past president of Pakistan Society of Interventional Cardiology. The presenter is Dr. Noel Somasundaram. He is the consultant endocrinologist and diabetologist at Diabetes and Hormone Center, Colombo. He is the president of SAFI, project lead Sri Lankan Diabetes and Cardiovascular Initiative, deputy editor of Endocrine Reviews. Sir, please join us on the stage for your talk.
Ladies and gentlemen, thank you once again. Thank you, PES, for inviting me. This is my 6th trip to Pakistan, particularly for endocrine society meetings, and my second to Lahore. And I love the company, the hospitality that is given to me. And today I have been asked in this industry-sponsored one to talk of this topic, emerging role of SGLT2 inhibitors in cardio-renal disease. My professor, more than 3 decades ago, showed me these slides. He is today very unwell. He probably can't remember the fact that he's shown this slide because he's so unwell. But this slide is stuck in my head, and I think we should all remember that. What he tried to point out from this 1995 data is the fact that most of the deaths in diabetes patients occurs from CVD and cerebrovascular diseases. If you actually count up, you will see that 2/3 of the deaths in patients with diabetes occurs from CVD disease and morbidity. So if you want your patients to be alive, you need to keep their cardiovascular health in good health. So to look at a little bit more recent data, you can see that age-related incidence and prevalence of heart failure is rising. And so heart remains #1 cause of death, because if you see the bottom curve, the sliding down of the survival curve, heart failure is like having developed a terminal cancer for patients with diabetes. Further, if you look at the patients with heart failure, you can see that almost half of them, 45% to be exact, have got CKD. And that complicates matters because both of them feed back on each other. For example, CKD means anemia. Anemia means heart failure gets worse. If there is CKD, you can't do interventional because the creatinine is always an issue with contrast, and so on. So both of these contribute and complicate matters for patients. So if you look at diabetes population, you will see that 40% of patients, including in my clinic, have CKD. And that prevalence is rising as we speak. So having said and presented to you the problem, why do we get these problems? Why do patients with diabetes get heart and kidney issues? At least these are the risk factors that we know. So most of them are reversible, as you can say. They are hypertension, obesity, smoking, which are modifiable. Then patients with ischemic heart disease have higher prevalence of getting renal disease. And at the bottom you see the 3 microvascular complications. If you have any one of them or in combination, your chances of any of the macro or the renal complications are higher. If you delve into the pathophysiology and ask what actually is going on, remember these 3 model hypotheses, which I will come back to as we discuss the treatments. The metabolic dysregulation, which is hyperglycemia, which drives modifications of the cell lines, you get ages, and that causes inflammation. And then on the other side, we have the hemodynamic perturbations, which means the renal tubules are reabsorbing glucose, which leads to inflammation in the kidney. Because of the sodium delivery to the macula densa, you have increased intraglomerular pressure. So this process causes proteins to leak out, which causes fibrosis. So you can see that the patient is actually caught up in this cycle of metabolic, inflammatory and hemodynamic issues, which leads to progression of the fibrosis of the kidney. And similarly, in the heart, you can imagine a similar process goes on. So at the bottom, you see the progression of the kidney podocyte from being impaired with hypoglycemia to getting oxidized, then getting glycated, and then getting inflamed upon, and slowly the cells die, and that causes the fibrosis. Having said all of that, can we do something about this? Way back, 3 decades ago, when my professor showed me that slide, we had very little. We had seen UK PDS data which had some effect on these, but you and I know that over time, these have been frustrating times, because once a patient gets elevated creatinine, we know, despite our best efforts, the creatinine keeps sliding up, and we cannot do much about it. The dialysis rates and end-stage renal disease keeps rising. We could not do much. So can we do something about it today? In 2024, would we be able to treat these patients differently, those with heart and kidney disease? So that's the crux of the question I want to ask and present to you. So our key strategies when a patient has CKD will be to keep them alive. As my professor would say, keep them heart attack free and heart failure free. Can we do something about that? Can you avoid dialysis? Can you prevent progression of creatinine so that they become candidates for transplant? You and I know in our parts of the world where resources are limited, that having patients with end-stage renal or heart disease is a massive problem, because we have resource limitations and we don't really want to go there. So if you forget all of the other slides, this will be my take-home slides, because what we've come to realize from recent data over the last decade, and particularly over the last 5 years, even during COVID, these were perhaps the only positive news that we've got, that we have 4 pillars to work upon for patients both with kidney disease and with heart disease. And I'll show you data on how we use these 4 strategies, the 4 pillars, to keep our patients alive. So from creatinine sliding upwards, a kidney failure progressing upwards, we have a new scenario where we can hold kidney disease in remission. Or they have elevated creatinine, but we can hold patients there and give them 10, 20, 30 years without renal replacement therapy. So if we can do that, then that's what we want to do. So that's why I've said this will be my take-home slide. So we have the first, where we have ACE inhibitors and ARBs, and in patients with heart failure, addition of neprilysin inhibitor, what we call the ARNI, have transformed the way we treat patients. And second pillar is the SGLT2 inhibitors, particularly Empagliflozin and Empagliflozin have come up to play a major role in patients with heart failure, and also lately for patients with kidney disease. And then the newer trials are showing us that GLP-1 receptor agonists play a role for atherosclerotic cardiovascular disease as well as for patients with CKD. And I'll show you some data on that. And the newer mineralocorticoid receptor antagonists, which are finerenone, which I will speak about. So I'll speak for the next perhaps 8 minutes on the these 4 pillars. So the first pillar is the RAS blockage. In the 1980s, in type 1 patients, we saw from one study that captopril had modest effect, 11% progression to end-stage renal disease versus 17% in the non-captopril group. And then in the 1990s, we saw the other 2 trials, the renal study which used enalapril and the IDNT study, and where we saw modest improvements or modest prevention of progression, but that wasn't good enough. We now begin to have started using RAS blockers, but we know that it's not adequate because there is escape. So we've tried to combine in the 2000s the ACE inhibitors plus spironolactone, for example, but the double blockade had been failure. So we haven't been able to combine because somehow the system, the renin-angiotensin system escapes. However, the RAS blockade using either ACE inhibitor or ARB is the first step we take when our diabetes patient with hypertension requires therapy or they have developed albuminuria. But we have 3 more pillars which will help us. So in the recent 5 years, we've realized that as opposed to RAS blockade, we have a more powerful one, where SGLT2 inhibitor treatment prevents progression to end-stage renal disease by a bigger percentage, 30% versus 6% from multiple studies. And SGLT2 inhibitors have come to play a role not just in CV benefits as we've seen from the EMPA-REG study. We've also now seen EMPA-CKD study, the DEPA-CKD study where we've seen renal protection, and then modest reduction in blood pressure, very modest weight reduction, and we also now have many studies running internationally on liver benefits in metabolic liver disease, in kidney stone risk apparently is lower. Anemia gets better in CKD patients because the EPO production improves with the action of the SGLT2 inhibitors. Because they reduce the sympathetic tone, the atrial fibrillation rates are lower in those with the treatment on SGLT2 inhibitor, and there are few studies that are looking at Empagliflozin as a preventer of new onset diabetes in high-risk population, say obese people or those with PCOD in whom we use them sometimes. So the key actions come from these benefits, the glycosuria and the natriuresis, which cuts down in the kidney the inflammation and the provision of extra sodium to the macula densa. It decreases the intraglomerular pressure, it cuts down the age formation. As a result, the oxidation in the kidney and the heart becomes less. If there is less protein delivery to the tubules, there is anti-inflammatory, anti-fibrotic action. In the heart, we know the heart pumping action becomes better because now the ketones are, the fatty acid is now being oxidized into energy by the myocardium, which starts pumping better than in the olden days, and that results in antioxidant effect as well because we have less oxygen radicals inside the myocardium. And as I said, the sympathetic tone being decreased by the SGLT2 action is another effect. So having spoken about those 8 the modes of action, we can see the recent meta-analysis that has been published in Nature Reviews Nephrology just a few months back, and a busy forest plot, but you can see at the top kidney disease progression is prevented by 38%, kidney disease progression prevented even in people without diabetes. And then in the heart failure, you can see a more marked effect. Whether patients have diabetes or no diabetes, heart failure risk or hospitalization, death rates in heart failure patients is remarkably decreased. So SGLT2 inhibitors have come to play a role in those with high risk atherosclerotic cardiovascular disease, because heart failure can be prevented, both admissions and death rates are decreased, and also those with albuminuria and increased creatinine. Here is a drug that will prevent the progression to severe renal disease by 30%. So number needed to treat from the same review is here. So at the top you see the patients with elevated creatinine. If you treat 84 patients for 5 years with SGLT2 inhibitor, you can prevent 1 renal transplant. And in a non-diabetic CKD patient, if you treat 93 patients for few years, you can prevent 1 transplant. A more remarkable prevention in heart failure patients. If you treat just 22 patients, SGLT2 inhibitors, you can prevent 1 death. And in non-diabetic people with heart failure, whether it's reduced ejection fraction or preserved ejection fraction, treatment of 29 people prevents 1 death. And similarly, you can see the numbers needed to treat for heart failure hospitalization are also pretty low. This happens in heart failure because of this mechanism. On the left, you can see the red pathway where inflammation, oxidation, etc. makes the myocardium stiff, and that's why we have the stiff myocardium, which gives rise to heart failure with preserved ejection fraction, which we call diastolic heart failure. 5 years ago, in a similar forum, we didn't have a single treatment for patients like that. I think they were speaking about verapamil as a modestly effective, and nothing else would work. SGLT2 inhibitors make your myocardium work better, less stiffer, and therefore they work better. And as I said, in the same condition, SGLT2 inhibitors decrease the fibrosis, and therefore the myocardium recovers, the NO bioavailability and the inflammation go down, which results in myocardium working better. And similarly, you can see this is one example of the CKD data for the SGLT2 inhibitors where there is benefit. In the olden days, we wouldn't start an SGLT2 inhibitor if the patient had CKD. Nowadays, we actually are asked to start and not to stop unless the patient goes for dialysis. The third pillar, ladies and gentlemen, is the non-steroidal mineralocorticoid receptor agonist. As I said, there are the older drugs, spironolactone, eplerenone, etc., which are non-specific aldosterone blockers. We now have particularly finerenone, which is now available, and many others in trial. In short, the aldosterone binds to the mineralocorticoid receptor and causes fibrosis when it's overactivated. Finerenone is a good blocker, more specific than the other drugs, as you can see from here, the spironolactone, etc., do not exactly fit that, but finerenone is a better fit and therefore blocks the spironolactone, the aldosterone action more specifically, and more specifically in the renal tubule and heart. So we've seen the data from this Fidelity program where more than 13,000 patients have undergone CKD treatment trials, and we've seen about 20% reduction in advancement of end-stage kidney disease. And similarly, 14% improvement in the MACE in heart failure patients when they were treated with finerenone. The fourth pillar, ladies and gentlemen, is the GLP-1 receptor agonist. We've seen semaglutide and in the olden drug liraglutide, both preventing albuminuria and prevention of end-stage renal disease by about 20%. This is the FLOW trial that had been published recently, and we've seen benefit by about 20% in that trial. And if I were to put it all together, This is the diagram we started with. Diabetes kills because there is these three problems: metabolic dysregulation, inflammation, and hemodynamic perturbations. And you can see how these four pillars, the RAS blockade, the SGLT2 inhibition, and the mineralocorticoid receptor antagonism, and the GLP-1 receptor antagonism together complement each other and play a role in each of these three triads, which are the key killers in patients with diabetes. And so we finally have much more than what we had a few years ago. So if you were to combine this, you can see, for example, this one study where DAPA was used for decreasing albuminuria versus eplerenone, a mineralocorticoid receptor agonist. And when both were combined, you can see the decline in albuminuria was much more. So since I'm running out of time, let me just summarize. So I asked by asking the question, why do we have these problems, and we try to understand. How do we treat? We said we have these four pillars, and in my concluding remarks, I'll talk about the 8 steps that you can do. So the 8-step plan is the basic lifestyle and basic diabetes common sense treatment, and the rest of the 4 are our 4 pillars that I spoke about. So if you were to look at a guideline, like for example, this latest guideline from KDIGO, you can see the effect of lifestyle at the top, the 4 steps there. SGLT2 inhibitors as the first-line agent for patients with kidney disease, and then adding other drugs if needed. For patients with albuminuria, aiming for blood pressure less than 120 with a non-steroidal mineralocorticoid receptor agonist, and then adding other drugs for hypertension if needed. Statins for atherosclerotic cardiovascular disease, and then adding antiplatelets, ezetimibe, etc. if needed, and then managing anemia, etc. If your patient has diabetes and is obese, then you would use a GLP-1 receptor agonist. So you can see how we have these multiple steps, 8 steps in fact, for sensible diabetes management. But when you have a patient in trouble, here is the 4 pillars that you can use together. So if you were to look at the decrease in effect, so when my professor spoke 3 decades ago, we had ABC of diabetes, the A1C reduction, which could decrease renal disease by 25%. Blood pressure was a good intervention, but had 30% effect. And then LDL decrease itself was effective for 10% event reduction. And then we have these 4. Actually, the third one, ACE inhibitor, was here. So we have SGLT2 inhibitors, GLP-1 receptor agonist, and non-steroidal mineralocorticoid receptor agonist, eplerenone in particular, each of which have massive impact on the progression of CKD and in the patients with atherosclerotic cardiovascular disease and heart failure. So we now have much more to keep our patients alive. And I thank you once again for having invited me to beautiful Lahore and for being here to listen to my talk. Thank you.
Thank you so much. Due to the constraint of time, I would request the panelists to please give their concluding remarks on the wonderful talk by Dr. Noel.
Thank you very much. Great talk. I think as an interventional cardiologist, I really, when I have to do a coronary angiography or heart catheterization on a patient who has a long-standing diabetes, I really dread. And the reason I really dread is that most of the time I end up finding so diffusely diseased coronary arteries that I may not be able to really do anything. May not be able to offer them bypass surgery because the targets are very poor, may not be able to put a stent in because I really don't know where to put the stent in because there is so diffuse disease. So I think any intervention in diabetics that is going to help to improve the cardiovascular risk is kind of a music in the ears as an interventional cardiologist. So I think SGLT2 inhibitors Obviously, we have enough data now to prove that these are very helpful in actually has cardiovascular outcome benefit. So definitely my goal is almost every patient, even if they don't have diabetes, as I said, just because I really don't know, I don't have any other options. So I end up putting them on SGLT2 inhibitors, start with low dose and then continue. Obviously, patients with heart failure, there is clear cut evidence, now it's a class 1 indication that every patient with heart failure, whether it is heart failure with reduced ejection fraction or heart failure with preserved ejection fraction, we put them on again SGLT2 inhibitors. I think this is the first time as cardiologists we have been really working very hard to come up with some kind of therapy for patients who has heart failure with preserved ejection fraction. And this is the first time that we were able to find mortality benefit in patients with preserved ejection fraction as well, SGLT2 inhibitors. A lot of other trials with spironolactone and other drugs has really failed in preserved ejection fraction. So there are so many benefits of, at least in the heart, whether it is heart failure or underlying vascular coronary disease. For some reason, I don't know, I still kind of find, and maybe one of my colleagues from here answer that diabetologists, whether they don't believe it, but I have seen a lot of my patients who have coronary disease or not heart failure most of the time they are, but if somebody has atherosclerotic coronary artery disease, they are still will be on other oral hypoglycemics rather than SGLT2 inhibitors, which again, I'm not sure why that is the case. Lastly, one thing you pointed out, and I want to really bring it up here also because I see it almost every day. Like a lot of patients who has like elevated creatinine of 2.5 or even 2, and they have either heart failure or they have underlying even cardiovascular disease. If I put them on ACE or ARBs, they'll come back to me that they went to someone who have stopped it thinking that these medications are going to worsen the renal functions. It's other way around. I think creatinine itself is really not an indication to stop ACE or ARBs. I always put them on. You have to be careful. You need to monitor their potassium. You need to monitor their creatinine. But there is even minor elevation in creatinine after you start them on ACE or ARBs. But I would not stop it unless there is a significant hyperkalemia problem or there is significant increase in creatinine. The only time obviously you have to be careful is if somebody has a bilateral renal artery stenosis. That's the only time they can go into renal shutdown. Otherwise, most of the time my patients tolerate ACE or ARBs, even if their creatinine is 2.5 or 3, very well. And actually it has been, as you showed also, ACE and ARBs along with other medication has shown to decrease or slow the progression of renal disease. So please don't stop ACE or ARBs, those who have underlying CKD. Thank you.
First of all, excellent presentation. And just 2 points. It's very exciting times to be treating diabetes, kidney disease, and heart failure these days, because we have all these new tools available with the sodium glucose co-transporter inhibitors. You're giving drug which is managing diabetes, which is managing obesity at the same time, which is managing the CKD of the patient, which is managing the heart failure, and now there's data emerging that it is managing MASLD as well, previously known as NAFLD. I guess there's a session, you will hear about that in coming session regarding that. That's one part. So the guidelines are very clear, but Professor Bashir Hanif said sometimes he does not see the patients who should be on this treatment is on other medications, not this one. I think just more awareness is needed, but as far as the guidelines from American Diabetes Association, they are very clear regarding the use of sodium glucose co-transporter inhibitors or glucagon-like peptides. Secondly, the point ACE and ARB. If you talk to a nephrologist, most of the nephrologists will tell you that, well, there's some degree of nephrotoxicity with ACE or ARB, especially when they are going in the higher CRET range. It doesn't happen with everyone, but like what Professor Bashir Hanif said, the key is to keep these patients on ASA and ARB, monitor their renal functions. Normally, there will be a jump of creat about less than 30%. We expect that, which is the short run. In the long run, these patients will benefit for that. So the guideline for physicians who are sitting, my suggestion is, if your patient is on ACE or ARB with a creat around 2 or so, or you have started that, just repeat serum creatinine in next week and then 4 weeks later. If there's a jump of less than 30%, the patient can continue with the treatment and you can continue monitoring every couple of months. But yes, if renal functions, if the creat jumps up by 30%, then that ASR-ARB has to be temporarily halted, but it does not happen very often. That's the unusual kind of scenario, but certainly needs to be kept an eye. Thank you.
Excellent presentation, and you have already summed it up. 2 or 3 things mainly. One, when we are using this Penirenon as well as this SGLT2 inhibitors, so the electrolytes has to be watched very carefully. That's something. Then the most of the benefits in even heart failure are in slightly elderly age group. One of your slides did show that the benefits are more in elderly as compared to relatively younger patients, but these are the patients who are likely to have all those electrolyte related and other complications. And there is a slight paradox as well. Heart failure, hospitalization, mortality reduced, but overall cardiovascular mortality did increase with the SGLT2. So how that paradox can be probably explained, that there was net mortality benefit was not, but not there, although the benefit in patient with heart failure and especially in non-diabetic patients. So can we?
One last quick comment I wanted to say. The American Heart Association, American College of Cardiology guidelines on pre-op cardiac evaluation for the non-cardiac surgery just came out actually last week. And I was not really personally aware of that, so that's why I want to bring it up here, that they have recommended it's a class 1 indication to stop SGLT2 inhibitors 3 days prior to surgery, any surgery. So I think that you need to keep in mind, because I learned from these guidelines, so that's why I thought I'll bring it up here.
Thank you so much. This is all from my side. Now I'm handing over the stage to Dr. Afreen. Please join